We are live, please.
Hello, my name is Dr. Rishi Swarup. I welcome all of you for this AIOS webinar, Walk-in Patient with Corneal Scar. We're going to try and cover all the aspects of corneal scar, how to triage a patient of corneal scar, how to select which ones need intervention, and we'll try and cover all the different types of interventions that we do in scarred corneas. We have a plethora of cornea specialists from all over the world. We have an international chairperson, Dr. Audrey Rostov. Welcome, Dr. Audrey. Thank you for being part of this uh, webinar. I'll just quickly do the introductions for the faculty. So the chairpersons are Dr. Partha Biswas, who is the president of AIOS. He's yet to log in. Dr. Namrata Sharma is delayed in a flight, so I'm not sure if she'll be able to make it. We do have Dr. Audrey Rostov from Bellevue Precision Vision, Washington, and she'll be presiding over today's proceedings. The moderators are myself. I'm Dr. Rishi Swarup from Swarup Eye Center, Hyderabad, and Dr. Himanshu Matalia, my dear friend from Narayan Nethralaya, Bangalore. The co-moderators are Dr. Santosh Unava, who's the secretary of AIOS, and Dr. Manoj Mathur, who's the honorary treasurer of AIOS. The expert panel that we have are really most cornea specialists of the country, Dr. Arun Jain from Chandigarh, Dr. Rohit Shetty from Bangalore, Dr. Samar Basak from Kolkata, Dr. Somshila Murthy from Mumbai, Dr. Vardhaman from Pune, and Dr. Vikas Mittal from Ambala. We have a very interesting lineup of cases, and the presenters will be Dr. Sayan Basu from LV Prasad, followed by myself, and then we have case presentations by Dr. Deepthi Mehta from Bangalore, Dr. Prafulla from RP Center, New Delhi, Dr. Prabhat Nangia from Nagpur, Dr. Rasika from Kalyan, Dr. Rushad Shroff from Delhi, Sayan, I've already said, Shreyas Ramamurthy from Coimbatore, and Dr. Tejasri from Narayanipalli, Bangalore. And finally, Dr. Vineet Joshi is also now our international guest since he's abroad for some research in US, but otherwise he's from LV Prasad Institute, Hyderabad. So without further ado, I'll invite our star presenter, Sayan Basu, to tell us how to look at scars, how to triage them, and how to approach them systematically, and to give us an overview of the various management options for scarred corneas.
Thank you so much, Dr. Rishi. It's a pleasure to participate in this symposium and webinar and to be presenting to all of you today. So I've taken a slightly different approach in trying to reimagine how we would think about corneal scarring and also think about treating it. I was having a very interesting conversation last night with someone, and a conversation about life, and it made me think of this aphorism by Friedrich Nietzsche, which says that what doesn't kill you makes you stronger. So if you are participating in this webinar and you are alive, you have scars. You carry them with you. That is what defines you. Some of those scars are emotional, some of those scars are physical. But if you are human, then you have scars. And the reason that we scar is that it's a natural process of wound healing. The reason that we scar rather than regrow the part of the damaged tissue in the natural form that it was present in the first place is because we prioritize survival over function and speed and rapidity over precision. And depending on the tissue that is injured, it can either result in a cosmetic deformity or it can result in a functional deficit or a function limitation. So, life, as is the nature of it, gives us trauma, and we heal from that, and we scar and we move on. So the whole idea of scarring and the biology of scarring is so that we can heal very quickly from injury, from inflammation, from trauma, and that we can survive that trauma and keep moving on, keep functioning, keep surviving. What is very interesting, if you look at the biology of scarring, which I'm intentionally going to avoid in this presentation because I don't want it to be, I want it to be clinically oriented, and because the whole symposium is set up so nicely, talking about all the different interventions. But what is interesting is the biology of scarring is conserved across species and across tissues. So the basic mechanism biology is very similar. What happens in the cornea is also what happens in the skin, what happens in other tissues, and also what happens in other species and animals. That's why you can study the process of scarring in one species and apply that information uh, to humans. And that's why, we have animal models and we do preclinical trials before we come up with new therapeutics. I guess also the reason we are discussing corneal scarring in this symposium and why it's clinically relevant is because corneal scarring and opacification because of corneal scarring is the number one cause of corneal blindness in India, unlike in the West, where it's mostly endothelial dysfunction and keratoconus. Of course, keratoconus itself also causes scarring. And most of the scarring is so bad that penetrating corneal grafts don't do very well in these cases. So for those of us who are in the business of managing scars, we have to look around for other options as well. And in today's webinar, we will go through all the plethora of options that are available. And at the end of my presentation, I will try to rationalize and try to arrange them in an algorithm which will help in clinical decision making. So we have lamellar surgery and keratoprosthesis already, in addition to penetrating surgery for visually disabling and blinding scars. What we also have on the horizon are stem cell based therapies and bioengineering. Again, in my presentation, I'm not going to talk about this because I don't want to steal anybody's thunder. And Vineet is going to, talk about or discuss the case on the stem cell therapies or present a case where we used stem cells for treating corneal scarring. So the normal cornea in its structure is very simple. You have mostly extracellular matrix with epithelium on top and endothelium at the bottom, and the stroma is maintained, by because of the keratinocytes, which are there in different densities in the anterior, mid, and posterior stroma. And if there's any injury, inflammation, infection, then this normal arrangement of and the beautiful arrangement of the corneal stroma is deranged. You get deposition of abnormal extracellular matrix, and that results in a hindrance to light transmission, and which is what clinically we see as scarring. So essentially, the optical property of the cornea is deranged. So this is an OCT scan essentially showing a normal cornea on top and a scarred cornea, a healed keratitis scar at the bottom. But what is important to understand here, and I think this is something that we sometimes don't pay a lot of attention to, is that a scar is not just an opacity. So definitely there is opacity that happens because of it, but usually scarring is accompanied also by thinning of the cornea, by flattening of the corneal surface because of the fibrotic process which involves the myofibroblasts and the actin myosin filaments which contract. And there is also irregularity of the surface, which is a combination of all of the things that have happened before. So when you try to fix a corneal scar, not only are you trying to get rid of the opacification, but you're also maybe trying to address the thinning and the flattening, or at least the irregularity. So in this very interesting paper that I have cited below, Vineet, when he was working with me as a fellow, he did this very interesting study on patients with superficial corneal scars and showed that what influences best corrected vision in these patients is not the density of the opacity as much as the surface irregularity and the higher order aberrations. So, in fact, in at least superficial scarring, if you correct the higher order aberrations, then it could restore better vision rather than trying to get rid of the opacification. So a scar is more than just an opacity, and irregularity and aberrations also play an important role in how it affects vision. What is important when we try to address scars also is how we measure them. So right now there is no commercially available modality or algorithm that automatically measures and gives us a volumetric assessment of scars, but there are certain ways that it can be done. You can measure a scar in terms of its thickness, the surface irregularity, the reflectivity, and there is the densitometry function which is there in Scheimpflug imaging systems, which allows you to look at the light scattering and quantify it. And what we are working with in collaboration with Oculus right now is to have a objective way of quantifying this in the scar based on the Scheimpflug readings, so that we can do serial measurements and show how a scar is evolving, or how therapies are able to mitigate the amount of opacification in terms of the light scattering, the thickness, and the surface curvature over time. So this is something that is, I think, we are looking forward to, which can help us in looking at scars in a completely different way. Having said all of this, let's talk about the treatment of corneal scarring. Now, this is it's not as simple and mathematics. A lot of factors need to be considered. First of all, if the scarring is causing any functional or cosmetic deficit, what is the etiology, the location, the depth, and the extent? Um, Typically, for those scars which are not causing any problems with vision, we don't really need to do anything unless they are causing a cosmetic problem. Etiology is important because a lot of scarring that happens because of inflammation or infection tends to happen because of herpetic infections, and herpetic infections sometimes get super infected with fungi or bacteria, and then if the underlying herpetic infection is not treated, then it's a recurrent problem, and the inflammation keeps coming back. So every time you treat the scar, more scar comes back. So knowing what is the underlying etiology and addressing it is important. And then we'll talk about location, depth, and extent in a while. So not all scars need treatment, and some scars go away with time. I shared this photograph very recently in our Oculus Surface WhatsApp group. This is a patient of Steven Johnson syndrome who had a bacterial keratitis and had a scar. We treated him with minor salivary gland transplantation, and this is over a course of 10 years. Now, if you look at his cornea, you can hardly see the scar because the underlying problem has been removed. The patient was young, and the cornea remodeled and became optically more and more clear over time. You see this in other conditions as well. This is a case of very severe limbal VKC where we have treated the patient with systemic anti-inflammatory medication, in this case tacrolimus, and the cornea has cleared significantly. You can see how badly scarred it was earlier and how that has remodeled over time with the central cornea clearing up. This is a patient with limbal stem cell deficiency following chemical burn, treated with SLED. And even initially after SLED, you can see that there is some amount of residual haze, but this haze has over time gone away. So a lot of the cornea has remodeling potential, especially if the patients are very young. So especially, if you have addressed the underlying cause, you can expect the scars to remodel and clear over time, and the vision can improve. This is another case of a patient with chemical burns treated with SLED, and the cornea has completely cleared up over time. And if you see this from a macro distance, you will not be even able to make out the patient at surgery. And sometimes you need to take care of the inflammation and prevent the scar from progressing. A patient of SJS with an infection treated with tissue adhesive glue and BCL application, then treated with steroids, kept on immunosuppression, and over a period of time, you can see how much of the scarring and the vascularization has mitigated. And then you can, fix the vision with other modalities that we'll discuss. So I think I'll finish with this algorithm, and I think that a lot of what I'm talking about in this algorithm will be discussed in the subsequent presentations, and this will, segue very well into my talk. So, if I think the main takeaway and the way that I think about scarring is that there is an opportunity for us to prevent a scar from forming completely or deranging the architecture of the stroma if you treat the inflammation, and this is where steroids come in. When you have an early scar where you just have the myofibroblasts, the fibroblasts before they become myofibroblasts, you have the option now of using losartan to prevent that conversion and reverse it so that you don't get a formed scar. So this is where medical therapy comes in. Of course, here you have to, treat very early before the architecture is completely deranged and you get an opacity. So if you catch the inflammation early on using medical therapy, if the scar is just starting to form, or you have post-operative haze, like you have post-cross-linking haze, or you have post-PRK haze, that is where I think losartan would particularly be helpful. We already use steroids. And we are also working with the MSC therapy, where I think that it would be applicable in both these instances. So it would cover what already is covered by steroids and losartan. Once you get a formed or mature scar, it of course depends on the depth and the extent and how much deficit it is causing. If it's only a cosmetic concern, then you can think about tattooing or cosmetic contact lenses. And if it affects vision, then based on if the scar is superficial and deep, you have multiple options. And the subsequent presenters will talk about and tell us about all of these options. Um, you have the option of rigid gas permeable contact lenses, which include scleral contact lenses. You can do cataract surgery and correct the irregularity of the cornea by using a toric IOL, compensate for it. You can do a surface ablation procedure to improve the surface regularity and improve vision. You can also do a superficial anterior lamellar keratoplasty, which may or may not use a femtosecond laser. And if it is very deep, then you need to replace the abnormal stroma, and which you can do either by deep anterior lamellar keratoplasty, and if it is a full thickness scar or there is iris incarceration or anterior segment disorganization, then you need to do a full thickness PKP. So I think this is the way that I think of corneal scarring, and I think that a lot of interesting stuff is happening in this area, including medical therapy, losartan, mesenchymal stem cells, and I'm really looking forward to the remaining presentations, which are going to elaborate on all of these therapeutic approaches. Thank you so much.
Thank you, Sayan. I think you gave a very nice philosophical take on how to approach corneal scars, and at the same time, you covered everything and showed some beautiful before-after images of interventions. I think one point which is very valid is that a scar is not just the opacity, it's also how it distorts the cornea, which affects the visual quality. And very often, if we can address just that, the patient has significant improvement of the vision, even if you leave behind a lot of the scar. I'll invite our chairperson, Dr. Audrey, to give her comments, and if anybody among the panelists have any points to share, it will be nice.
Thank you so much. That was an excellent presentation. I especially liked your introduction about what doesn't kill us, make us stronger. So thank you so much for that. I think that it's very interesting that you're working on the concept of Scheimpflug imaging and grading, because you're right. One of the issues I think that would really help us all internationally is to come up with a international way, a way that's a grading method that we can all use, that's accessible. And Scheimpflug, as well as OCT based. I think even OCT based, although of course we can measure the scars, it would be really, really helpful to have some sort of grading system. I think would be very beneficial. And so thank you for doing that. I look forward to hearing the results of your research. But also just a comment to include OCT based as well. And thank you for a lovely presentation.
Thank you so much. So we are really looking forward to, the technologies that are now coming in, especially the Pentacam OCT, because that would allow us to use these two technologies in sync. Because right now we have different platforms for the OCT and different platforms for the Scheimpflug. And this is the first time these two technologies are coming together. So I'm looking forward to, using that. And like you correctly said, and I agree that the OCT is also very important because it gives us much more granular information, and also depth information, which Scheimpflug does not give.
I believe at Narayan Nitrale, Dr. Rohit hasn't joined us yet. They're also working on Bowman's topography with OCT. Any comments from Dr. Samar Basak or any of the other panelists? Dr. Himanshu, my co-moderator.
No, amazing. I mean, it's so nice to hear Sayan. When Shayan talks, I just feel that he keeps going, it doesn't stop. So it's really nice, Sayan, that you actually took the entire way where the scar forms and how we can treat it if we know the etiology. One quick thing about the what Dr. Audrey put across very rightly, the role of OCT part versus the Scheimpflug part. One limitation of Scheimpflug is that backscatter of light, whenever there is significant scarring, does not allow us to accurately measure the anterior surface, or even if it's too dense, even the posterior surface. So in such kind of cases where the anterior surface is relatively regular, even a placidose-based device can give you a reflection from the anterior surface or the tear film, rather than rather than suffering from the backscatter. But the best would be then OCT-based device, which would allow us to get more accurate information.
No, I agree, absolutely.
Great. We'll move on to the next talk.
So next, I would like to invite my best friend, my co-moderator tonight, Dr. Rishi Sarup, to talk on phacoemulsification in opaque cornea. Over to you, Rishi. And thank you for putting amazing program together, and I'm really going to enjoy the entire program.
Thank you. Thank you. So the topic that I'm going to be covering is phacoemulsification in opaque cornea. So basically, although we do have scars can affect the vision, but many of these scarred patients do also have cataracts, and very often just addressing the cataract can take care of a lot of the visual problems that the patient is having, and the distortion that the scar may be causing may also be addressed with the cataract surgery by using specialized lenses like toric lenses. Or one could irregularize the cornea a little bit before we do the cataract surgery. So I'll just try and cover some of the aspects, and then other things will be covered in the cases that we come discuss subsequently. So when we say scarred corneas, traditionally we've been talking about nebula, macula, leukoma, but this is a classification based on only the density of the scar. And we know that it's not just the density of the scar, but also the location of the scar and how large it is, and how it is affecting the corneal shape. All these things will play a role in how much it is going to affect our visual quality. So the decision tree, I think, is threefold. One is if it's just an eccentric scar that's not really causing too much of effect to the pupillary axis, and if it's not really distorting the cornea much on topography, you can simply ignore it and go ahead and proceed with your regular cataract surgery. And because it doesn't affect your visualization, you don't even need to modify your technique in any way. If you have something like a paracentral scar that is affecting your visualization and also causing some, is likely to cause some effect on the visual quality, either because of the way it impedes light from transmitting into the eye, or because of the way it's distorting the light rays because of the flattening of the cornea, then you have to do some additional measures. Maybe you have to regularize the cornea first with a laser or some sort of a topo-guided ablation, or you have to use some additional measures during surgery to help improve your visualization, or etc., which I'll come to in the subsequent slides. And of course, it's a very central, deep scar, which is just not going to allow you to see. Then you have to address the scar with a keratoplasty, which essentially you could combine it with the cataract surgery, or you can do it sequentially. So when we're talking about phacoemulsification in scarred corneas, one is the problem of visualization. You want to make sure you do all the steps of cataract surgery properly and safely without a complication. So for that, you have to make sure you see well. And if the scar is not allowing you to see well, then you have to do some things to improve your visualization. There is a higher risk of complications, so we have to be mindful and slow. IOL calculation can be a challenge because you can get a distorted cornea, so you may have to use advanced devices to aid in better IOL calculation. And of course, the choice of IOL also comes into play. So if you have a lot of cylinder corneal astigmatism, then you may be able to use toric IOLs. But if you have a lot of irregular astigmatism, then it may be a little tricky to use toric IOLs. And I'm sure one of the speakers will come to that in the later part of the So this is just a little video that I had on some tips to improve visualization in opaque corneas. So one of the simple pearls is if you have an irregular cornea which is irregular because of a scar, one of the very simple things that you can do is just put dispersive viscoelastic on the surface, and you can keep putting it again and again. And what happens is the scar tends to kind of depress the cornea a little bit, and if you put the OVD, your surface becomes more smooth, and sometimes you have a good 25-30% improvement in the vision. The second thing is using light. So you can use an indoor illuminator either from the outside, like tangential illumination, or you could even put it inside the eye through a side port. Some people even use a chandelier illumination, but for that you'll have to go past plana. You can see how just putting the light obliquely at the limbus, you can see what is going on inside the eye in a very, very opaque cornea as well. In fact, it helps in each step of cataract surgery, right from rhexis till cortex aspiration. And it's an invaluable tool that I think all cataract surgeons should have. You have very cheap light LED light sources that are available, and you just have to connect your fiber optic cable. You don't really need an advanced machine for that. Somebody's even developed a handheld light source which can be connected to your fiber optic probe. So you can see that even though this cornea is quite opaque, you'll see once the oblique illumination goes away that it's quite significantly scarred in the center. Using that endo illuminator significantly illuminates the pieces, and you're able to safely do your cataract surgery without any problem. So small things like use of OVD and right direction of light can help you see. In corneas like these, use of stains to kind of stain the capsule will help us visualize the capsule better. You can use pupil expansion devices so that you can see everything that you're doing, and it becomes a lot safer. So simple measures like stains and use of expansion devices also make the procedure much safer. Sometimes if the problem is in the epithelium, especially you have a case like this where you have a Salzmann nodular degeneration, or if your epithelium has become edematous for some reason, it may be reasonable to just take off the epithelium and then proceed with your cataract surgery, and suddenly your view becomes a lot better, and possibly go back later. So the reason I wanted to show this video is that we don't really need very advanced maneuvers. Sometimes simple things can help us see a lot better and do a safe cataract surgery in most of our cases. When you have decided to do a triple procedure, combining it with some sort of keratoplasty, one could do a penetrating or a Dalk or an endothelial keratoplasty triple, of course. Traditionally, when we think of a penetrating keratoplasty triple, we remove the corneal button and then an open sky cataract surgery like so is done. But we all know that this has the risk of positive pressure. You can end up losing the lens, you can lose vitreous, and then the whole outcome of the surgery gets significantly compromised. You can have risk of expulsive as well. And in such eyes, sometimes it may be difficult to also place the intraocular lens in an open sky. So what I've started doing for many of my cases is, obviously, if you can see reasonably well, you'll go with a closed chamber phacoemulsification or a small incision surgery and then do the keratoplasty later. But if you can't see so well, then it's reasonable to actually do a lamellar keratectomy, remove, say, about 50, 60, 70% of the stroma till the time that you're able to see reasonably around the opacity. And then you can use all your special maneuvers like endo-illuminator or using OVD on the surface of the cornea, etc., using stains to help visualize structures inside the eye so that you can do a safe surgery. And then you go ahead and complete your cataract surgery, implant your lens, and then subsequently you can just excise your button and complete your penetrating keratoplasty like a regular case. So almost in every case, it is possible to do a closed chamber phacoemulsification if you follow this approach. Of course, there are exceptions where you have, if you have severe distortion of the host, or if there's a lot of cyanic K, etc., you may not be able to do that. But in most cases, you're able to do this. Now, this is a patient who's having a Dalk triple, so the entire stroma has been removed, and you can see that Dua's layer is quite tough. So you can actually proceed with your cataract surgery as usual. Maybe you can just keep your bottle height a little low. The optics do seem a little distorted, but you can actually just go ahead and do a routine cataract surgery after removing the stroma, and then you can put your lens in and then switch your button just like a regular Dalk. So, of course, endothelial keratoplasty also can be combined, and one of the things that it's not relevant to this talk, but your IOL calculation has to be appropriately corrected depending on whether you're doing a DMEC or a DSEC. So to conclude, cataract surgery in opaque corneas may pose challenges with IOL calculation, selection, intraoperative visualization, and propensity to complications. Using an endoilluminator, simple steps like trypan blue, pupil dilators, etc. will help visualization be much better and make the surgery safer. Closed chamber phacoemulsification is preferred and possible in almost all cases where cataract surgery has to be combined with the keratoplasty. Thank you.
Thank you, Rishi. That was really wonderful and quite exhaustive topic, which you could concise into a very short period of time. May I ask her panelist, Dr. Somshila Murthy. Somshila, you deal with quite significantly bad corneas, as well as cases which have posterior seneca, uveitis or something. Can you give us some tips? How do we decide when it's the right time to go ahead with the cataract surgery? Can we wait for it or something? Anything, if you can give us some clue about.
Thanks, Himanshu. First of all, Rishi, excellent talk. I think Rishi pretty much covered the surgical tips, at least in most of these cases. So I do often see very bad in post-inflammatory, for example, viral ketouveitis and various other inflammatory causes. In fact, recently we had a patient who has Mycobacterium tuberculosis, uveitis, as well as bilateral corneal scarring. So these patients, when you go in for surgery, one of the, well, apart from surgical prowess, I think one of the other decision-making or make or break for the cases that is the inflammation well controlled. So these are situations where you cannot visualize the anterior chamber well, so you have to use some other clues. In these patients, I often use the ASOCT, in fact, because especially in recurrent viral keratitis, because below the scar, you can also have corneal edema, especially in active episodes. So I serially follow up this patient if the patient comes with an episode of, say, stromal viral keratitis, and follow up the patient till I think that the cornea is now scarred and give a good cooling off period, and then go ahead and plan cataract surgery for these patients. And of course, you have to use all the techniques that Rishi mentioned. I had one question for you, Rishi. Himanshu, did I answer your question reasonably?
Yes, Somshila. Thank you.
Thank you. If not, if then I had a question for you, Rishi, and this is more because Sayan has set the stage for more of a philosophical way of looking at things, or maybe a real world situation that we have. So we have a lot of patients, as you know, and everybody from India knows, and Audrey has seen several such patients in developing countries, where the patients have adherent glaucoma since childhood or have corneal scars due to healed keratitis. So my principle has always been that if I have a very much older patient, so then I really don't push too much on addressing the corneal problem, but just go ahead and deal with cataract if it's a cataract that has come up, and see the visual improvement. And for a younger patient these days, although I still don't offer corneal transplant, but I do tend to offer at least corneal tattooing, because I think aesthetics is also very important especially for any age group, actually, not just young or old. But is there some different way in which you approach these patients, Rishi?
So I think that's absolutely correct, ma'am. Whenever it's possible, if we can get away without doing a corneal transplant, that's always preferable. And if the child is already beyond a certain age, doing a keratoplasty also will not really achieve much if they're already amblyopic. Your point about tattooing for aesthetic is very well taken, because especially in this newer generation, I think they are very sensitive, and they're, for some reason, I think their mental health issues are a lot more than our generation was. Maybe I'm biased because my kids are in that stage. And I feel that, small things like this can affect their personality in the long term. And it's very important to keep that in mind and address it.
So I guess what I was trying to emphasize, Himanshu, is that, and because I've seen that, tendency is to have to operate on patients with adherent glaucoma without paying adequate attention to history. So it's very important to ask for the age of onset, because you might, yes, you might clear the visual axis, but the patient is not going to recover vision. I'm not saying it's a bad thing to clear the visual axis, but we have to explain, and we have to first of all understand that what is the visual prognosis for such patients.
So I have
Basically,
one
what you're
question
trying
for
to say is,
Dr.
even if
Audrey.
it's an elderly patient, if this adherent glaucoma is from childhood, it's not really going to benefit from a transplant, and just addressing the cataract might be reasonable.
So one question for Dr. Audrey. Simple thing. A lot of time we get this confusion. Like somebody, and with your experience, you would have treated many of such kind of patient. Many of these patients with corneal scar, they do very well with contact lenses, hard lenses, RGPs, and scleral lenses or something. So when time comes to operate them for cataract surgery, what do we do if they're comfortable with the contact lens? Do we go ahead and still put a toric lens, or we don't go for toric lens? How do we solve that kind of confusion? Because if we put a toric lens, and on top of that, if which is the related to the corneal astigmatism, on top of that, if we put a contact lens again, I think it's going to negate everything. So how do we solve this?
Well, I think it depends on what type of contact lens. If you're using a scleral lens, then even if you put a toric lens in, you can still correct the residual astigmatism or residual refractive error still with a scleral lens. And so I think that I always try to maximize somebody's vision. And I just had patients, especially I see this with in my country with keratoconus. And I think it really depends on what the issue is for the corneal scar. If it's someone, for example, with some astigmatism, with keratoconus, I think toric lenses can work really, really nicely. And then you can, if need be, you can correct the residual with a scleral lens or a gas permeable lens. However, if you're talking about someone who has a very significant, as you said, corneal scar in the visual axis, you have to ask yourself, what are you trying to achieve? Right? That's always like, what is your end goal and what are you trying to achieve? And so there, using a toric lens may not make sense. I also use the IC8, the pinhole optics lens, and I find the IC8 lens can also be very, very helpful in terms of a little bit of a corneal scar in the visual axis and such, where things are irregular. And then you get that pinhole effect. Also with RK scarring, multi-incisional RK, I've used that very successfully. And so I think that these are, some different options. And you're right. I mean, if someone is a successful contact lens wearer, then, you have to ask yourself, what is the end goal and what are we trying to achieve? But I do think that a toric lens is a reasonable option.
Thank you. So nice.
We
Thank
have
you.
some questions on our YouTube channel. I'll just ask them to sign. This one's for Cyan. Please, can you explain the difference between corneal haze and corneal scarring or opacity? How do we differentiate between a scar and other types of haze in the cornea?
Okay, that's excellent. That's an excellent question. So haze typically is what we refer to as is superficial, um, loss of corneal transparency, and this happens usually when you have uh, some kind of inflammation or trauma that is done to the anterior part of the cornea, which is most typically seen post like cross-linking or laser ablation, PRK, etc. So there the process is you mostly have like epithelial hypertrophy or hyperplasia at the histological level, and you also have myofibroblastic transformation of the keratocytes. When the keratocytes normally are transparent, when they become fibroblasts, they are still quite transparent, but when they become myofibroblasts, then they express actin and myosin filaments, which are translucent and they are refractile, and that adds to the light scattering and it looks like haze. So the biological process is a little different. When you have inflammation which is deeper in the stroma, there is loss of stromal architecture, and you have the fibroblasts create new extracellular matrix. That is what we call a scar. So a haze is like this healing response where there's no new extracellular matrix that is laid down, but it is more like a reactive, transformation of the epithelium and the keratocytes. Whereas when you have actual derangement of the extracellular matrix and abnormal collagen and proteoglycans being laid down, and that is basically what we call a scar.
Well, are there any in vivo confocal microscopy features that help us differentiate a scar from other forms of haze?
I think one is the depth of involvement. You can, I think, pretty much make out clinically, either on the OCT or even with the slit lamp examination. In the in vivo, if you're using confocal microscopy, what you would see in haze is this. You'll see the reactive keratocytes or the myofibroblasts, which are translucent or hyperreflective. And in a scar, you would just see a lot of light scattering. You'll just see white.
There's one more question on the YouTube channel, which I'll ask Dr. Somshila to field. And this is, if the scar is post-viral, do you give oral antiviral prophylaxis before doing cataract surgery? And if yes, what is the protocol? This is from Dr. Nidhi Jaipuria.
Yeah, for sure. If it's a patient who's under my care, then I think the prophylaxis would be going on for quite some time. And definitely I would give acyclovir 400 BID or valacyclovir 1000 OD for these patients. And I recommend that you do.
Thank you. I think we'll move on in the interest of time to the case presentations now. The first case presentation is actually something I've been really looking forward to hearing. It's by Dr. Vineet Joshi, who is a faculty at L.V. Prasad Institute and is currently in the US pursuing a research fellowship, I think. So he's going to tell us about the use of mesenchymal stem cells in corneal scars.
Thank you, Dr. Rishi, for the invite, and thank you, Dr. Sayan, for giving me a chance here. Yes, it is still dark here, 5:30, but I snoozed at the right time. I was very anxious whether I will meet you guys on this time or not. But I'll take you through a quick case where we are currently conducting a clinical trial in LVPI, and how the translational effects of the human uh, limbus-derived mesenchymal stem cell therapy would look like in the coming years. Now, if you talk about corneal scars and the spectrum of what we treat in the clinics, when I was a fellow with Dr. Sain, I used to discuss that, for all of, do we really need, contact lens or just corneal transplants, PTK? We have been doing this since so many years. Is there anything new that we can do, for the spectrum of these cases? And over a period of years, we've worked on this, and now there are quite a lot of possible options that are coming up for us that can actually change the way we manage corneal scars. Um, in this scenario, what you're seeing is different spectrum of corneal scars based on the severity and depth. Like the ones on the top are the superficial scars, probably less than half thickness depth. Typically, what we see in small or less severe microbial keratitis, which heal soon, probably within 1 or 2 weeks' time. A slightly advanced version where the scarring extends beyond the half of the depth of the cornea, where you see some amount of flattening and volume loss. And then we see a form of a diffuse scarring involving the full thickness of the cornea, but still very much located in the center and not leading to a lot of vascularization. And the advanced one where you see a lot of vascularization, full thickness involvement, and probably also inflammatory changes in the anterior chamber. And over a period of time, we've realized that each one of these would probably need a different form of therapy. And what I'm about to show you is the application of mesenchymal stem cells for the first type of corneal scar presentation, which is superficial corneal scars, and how their effects can actually be beneficial to us in day-to-day practice. So typically, a case with less than half thickness corneal scarring, as Dr. Sain showed, that we tried to find the in vivo metrics for corneal scarring, which would tell the story of a scar through images like ASOCT and topography, and also the Scheimpflug imaging. So to help us, give the exact quantity, the amount, and severity of the scar. This all started when Dr. Sain visited the University of Pittsburgh lab with James Funderburg, where they found out these MSC therapeutic corneal remodeling potential of a certain subset of these cells, which were found in the limbal niche. And these showed similar remodeling properties like the corneal stromal stem cells. And that's where this whole type of this whole therapy or the idea of this therapy began. So what we typically do is we take human cadaveric corneas, we dissect the limbus out, and we cut them and we treat them with collagenase 4, and we culture them until third passage, and then we isolate a pure population of mesenchymal stem cells, which is then stored in a media. And the novelty here was that you can mix this the pellet of the freshly prepared cells with fibrin glue, which we routinely use in all our ocular surface procedures. So then these cells are usually around 50,000 to 100,000 cells are mixed with fibrin glue. They are now ready to be sent to your clinic for application on the corneal surface. And I'll just take you through the procedure of how we do that. We currently have 2 clinical trials ongoing. We have completed their long-term follow-ups now, where we have included patients who are having these type of superficial scars, secondary to either microbial keratitis or injuries. And I'll just take you through the procedure of how do we deliver these cells on the surface. So typically what we do is that we scrape off the epithelium on top of the scar. And now this fibrin glue, which is loaded with this pellet of freshly prepared mesenchymal stem cells, are delivered on the surface of the scar. And they are sandwiched one layer on top of the other, like thick layer with cells, then thin, then thick layer with cells, again the thin layer of fibrin glue. So typically what it does is it contains the cells in that local region where the corneal scar is in the residual in the bed, and it stacks them one on top of the other. And it's a very minimal procedure because it doesn't involve any special surgical technique, and fibrin glue is very well used commonly in all ocular surface procedures. At the end, we just close this with a bandage contact lens and keep it in situ for 2 weeks until the fibrin glue degrades. So this is one of the patient which I wanted to show you, which we have followed up over a period of 2 years. A patient had as we were all discussing prior, the patient had this corneal scar in the visual axis, which led to flattening and also led to decrease in vision. After application of mesenchymal stem cells, typically by 1 week, we would see a lot of fibrin glue residues, which generally tend to resolve over a period of 2 weeks to 3 weeks. And then you will start seeing the effect of mesenchymal stem cells, which they usually start acting after 2 weeks in 1 month. And slowly, you can see serially that the intensity of the scar, the remodeling of the areas around it, the haze, the grayscale of the transparency, as you can see in the shine plug images, and even the surface, it smoothens the epithelium that gets restored is normal, and slowly the stromal clarity goes on improving till 12 months, and you can see that this effect kind of continues till 24 months. So basically, mesenchymal stem cells are known for their tissue repair, remodeling features, their paracrine effects, their immunomodulation effects, and basically it is enhancing the native capacity of the cells, the native keratocytes in the area to lay down a healthy extracellular matrix, which is orthogonal and is able to transmit light and be transparent and retain that. And basically it is, amplifying that process over a period of 24 months. So typically these cells would probably be a part of all other therapies which will likely be a part of corneal regeneration therapy, which might involve even replacement of a volume such as EC extracellular matrix, or even if you want to replace and with a completely artificial bioengineered constructs. uh, these cells will remain an important part of all forms of therapy. So this is good. These are good initial results that we have seen with the mesenchymal stem cell therapy that which shows promising results of scar remodeling. And I think I'll stop here and we can take some few more questions. Thanks.
Thank you, Vinny. That was very nice and very interesting, exciting times ahead. I'll let your mentor, Sayan, give a quick comment on this, and we'll then move on to the next one.
No, thank you, Vineet. We are very excited about the possibilities with this technology. We've been working on this for the last almost more than 10 years now. This was actually just meant to be a phase 1 safety toxicity trial to establish the safety of that it's not causing any unwanted side effects of the GMP manufactured product. But we are also very pleasantly surprised to see the efficacy that it has had. We are now submitting these results to the Indian regulators, and hopefully we'll be able to start a multicentric trial soon. So especially institutes and other places that want to participate in the multicentric trial and want to use this therapy, which we will send in small syringes to you for your patients, and you can apply. We would like to have as many partners as possible in the multicentric trial. Thank you.
I'm sure all of us are waiting to try. We need a small suggestion in your images that you're showing serial images. You could also add topography to show how the surface of the cornea is also changing, maybe. We'll move on to the next speaker. Dr. Shreyas Ramamurthy from Coimbatore is a dynamic young surgeon leading the Eye Foundation, and he's going to talk to us about PTK for corneal scars.
Thank you so much, Dr. Rishi, for having me over and for giving me this opportunity, and thank AIS also for this opportunity. So PTK for superficial corneal scars, lesions is it's a very selective procedure, in the sense there are not too many scars that you'll find which are amenable for PTK. But whenever you do come across such diseases of the Bowman's and anterior stroma, it can be a very repeatable and reliable method of clearing the scars and improving visual acuity. So essentially, it all depends on the location of the lesion. Obviously, it has to be within the anterior 100-150 microns of the cornea. But whether it is central what is the basic pathology, whether it is diffuse, like you have in a dystrophy, or a general spheroidal, which is a band in the interpalpebral region, spheroidal degeneration, versus focal scars, or which may be central or paracentral. Again, it also depends on whether you have a smooth anterior surface or an irregular anterior surface, and whether you'd be able to remove the entire pathology or only a part of it. So just more to insight discussion, I'll quickly run through a couple of case scenarios, situations, and present the cases, and hopefully we'll have a discussion after that. So the first situation is a 45-year-old male, the gradual progressive decline in vision over the last 10 years. And as you can see that especially in the left eye, the visual acuity had dropped to 618. And when you see the clinical picture, you have this diffuse anterior stromal lesions, which is a kind of a honeycomb pattern, which is typical of the Thiel-Behnke corneal dystrophy. And this can very easily be delineated on an ASOCT, where you have the typical sawtooth-like undulating pattern of deposits, which is essentially causing this corneal picture. So in these patients, it's important to measure the depth. And I think like I've shown in this particular picture, the deepest part goes up to about 120 microns. It's not necessary that you have to ablate the entirety of the lesions, but really ensure that you reach a sufficient depth. So that is why even though we have planned about 100, 110 micron of ablation, we do it in about 3 stages in this, because the corneal surface is smooth and it is very regular. We will ablate the epithelium also with PTK. Then we do maybe 2/3 of your planned ablation in the PTK in the first stage, and then subsequently take the patient back to the slit lamp and see the extent of clearing. And based on that, you can then titrate or modulate the amount of ablation that you're going to do in the stage 3. Needless to say, you will apply mitomycin C for a longer period. The end goal is really reduction in the density of the lesions and greater visibility of the iris details. And it's important to take them back to the slit lamp before you apply the BCL and finish the case. Essentially because on your coaxial or on the regular illumination on the excimer laser, you may not be able to see the extent of residual lesions. Now, this patient did quite well, as you can see here, had a very clear cornea. The entire dystrophy in the central region was completely removed. What is not very clear in the slit lamp examination, but you can see on the ASOCT, is that there are still some mild residual haze in the periphery, but the central 6.5 millimeter of the cornea, which was ablated, is quite clear. And these patients, as often happens with PTK, you get this a central steepening, although here there is more of a cylindrical induction. And as you can see here, there is a great improvement in the BCVA from 618 to 66. There will obviously be residual errors, and your refraction can never be predictable, but at the same time, the improvement in the BCVA which we are looking for is achieved. Let me take you through again a similar this thing where again this is all part of situation 1. Again, granular dystrophy, especially the superficial variant, as you can see here, is very amenable to PTK. It's essentially, you can see it's only about 48 to 50 microns of the anterior stroma is involved beyond the epithelium, and they do extremely well. You can see almost the entirety of the granular deposits, except a little bit in the periphery, is all removed, and the vision also improves. Even in the variant where it's a little deeper, it is not mandatory that you have to remove all the deposits. A significant clearing with some residual deeper deposits is perfectly all right, and this does lead to an improvement in the visual acuity. Now let's go into a different situation where this is a patient who had a history of having undergone a PRK for about 4.5 diopters of myopia. It was done elsewhere, so I don't have all the preoperative details, and the mitomycin C, the duration, what it was applied was not good. But at presentation, while his initial visual recovery was good, it had subsequently dropped to 624. And this was the clinical picture. As you can see here, this is a post-PRK a significant, what would have initially started off as a haze, but now is a well-established scar. This is more than a year after the original PRK. You can see that it's a very irregular cornea of variable thickness, scarring which is more extensive in the paracentral mid-peripheral region, but there is also scarring which is involving almost the entirety of the visual axis. There is irregular surface and it is of variable density. Now, again, this is corroborated on the ASOCT, as you can see here, that in some regions the thickness of the scar is not as much, but as you go into the lesion itself, it is much thicker, and the epithelial thickness is also very variable, being quite thin over the area of the scar and nearly normal in the other regions. And the topography also shows a very irregular topography, and although not very reliable considering the extent of the scar. So in this type of situation, you won't be able to go ahead directly with a PTK, and you would want to combine it with a superficial keratectomy and do a PTK subsequently. So I'll show this in this brief surgical video, where you can see that in the extent of scar, now we are just instilling a little bit of paracaine to loosen the epithelium in a trephine. You can also use alcohol epithelectomy as well. And with nothing but a simple 15 blade, you can ensure that the most of the hypertrophic area, which is really partially epithelium, partially anterior stroma, can be nicely peeled off, dissected, and it comes off in multiple layers, as you can see here. Now, it's not just epithelium. There is some amount of anterior stroma as well, which needs to be scraped off. The role of PTK here is really to smoothen the bed subsequently. So we are not really removing the entirety of the lesion with the PTK, but once we have debulked it with the superficial keratectomy, because of the variable density, you then do a PTK to remove the residual amount of scarring which is there in the anterior stroma, and then to essentially give a smoother and more regular surface. Again, being a post-PRK Haze keloid kind of condition, although this patient had not undergone any surgery or injury in the past, so there was no real history of keloids elsewhere in the body systemically or on the skin. But you would want to put a mitomycin C for a longer duration. Generally, I apply for about 2 minutes in these situations for post-PRK Haze, and that really helps in improving or reducing the recurrence of scar. So really, there is a significant debulking of the scar, although you can see here that there is some amount of residual scarring which is left behind, and we've not been able to remove it in its entirety, and there is a risk of recurrence over a longer duration of period. So therefore, initial application of mitomycin C, longer application of the bandage contact lens to ensure that the epithelium has really become stable before you remove your BCL, unlike in your regular PRK cases where you might be removing it after 3 to 4 days, and a slightly longer duration of steroids to help in the wound modulation. This patient continued to use steroids for about 4 months. So the subsequent slide, you will see that in the ASOCT, although there is a thinning of the cornea, the most of the scar has been removed using the PTK and the superficial keratectomy combination, and there is significant improvement in the visual acuity. The pre-op refraction itself would have been very unreliable, and I wouldn't pay too much attention to it. But it's really the improvement in the best corrected visual acuity that we are looking for, and that has improved from 6/18 to 6/7.5 in this particular case. So really, it's the location and type which determines the choice of procedure, how you do it, and longer duration of MMC to reduce recurrence. We must remember that the ablation rates will vary when it is going through a clear cornea versus area of scarring. And therefore, if it's not a diffuse pathology, this difference in ablation rates can lead to irregularities in the cornea as well. And therefore, it's important that you don't use entirely only PTK to ablate the lesion. Use superficial keratectomy. If it's a irregular cornea, sometimes masking agents have also been used. But again, with masking agents, you have to be very, very careful that you don't put excessive masking agents, because you'll just be ablating the HPMC or what you have instilled on it. And it's important that even in Salzman nodules and other situations, it's better to actually do a keratectomy, remove most of the lesion, and then do the PTK. Of course, you will be inducing a refractive error because of the PTK itself, especially if you ablate deeper. But in most situations, you can achieve an improvement in the best corrected visual acuity. Thank you so much. I'll stop sharing here and look forward to the discussion.
Very interesting case, Shreyas. Actually, I had a very similar case like yours with focal scarring in after PRK that I actually did a trek for, and actually that did really well too, because you can focally remove the scar. But of course, this is a great idea too.
I suppose it'll be coming in the next talks about Trek and this thing, so I don't want to steal.
I guess let's combine all these discussion together. So three cases are there, and let's try to combine them. So your case next, I would like to invite my good friend Rushad to speak about Trek, and then Deepthi would be ready for topo-guided PRK. So all three we can take together in the discussion, and I'll just keep Dr. Vardhaman ready for leading that discussion.
Are my slides visible?
Yes, Rushad.
Thank you, Dr. Rishi, for inviting me for this wonderful webinar. So Shreyas put me in an easier position. He gave the background to this. I think I'll go ahead and talk about Trek and a case that had presented to us. This was a case where the patient presented with a localized paracentral scar. You can see it's involving the pupillary area as well. And it was actually a post-LASIK patient. The initial refractive surgery had been complicated. It was a femto laser with a vertical gas breakthrough, and then the surgeon had consequently still gone ahead with the excimer ablation. And you can see the nebulomacular scar over there. The rest of the examination of the anterior and posterior segment was within normal limits, but for a normal routine refractive surgery, this patient ended up with an uncorrected visual acuity of 20 by 200, best corrected 20 by 50 with a 6 diopter cylinder. And you can see the irregularity on the axial curvature on the corneal topography. So post the surgery, this patient was obviously very, very unhappy and upset with their quality of vision. On the ASOCT, you can again see the scar measured on the slit lamp about 5 by 3.5 millimeters, and the depth of the scar in one region was about 50, and it went up to about 133 microns deep, including the epithelium, when we looked at it on the ASOCT on the OptoView. And the eye trace was done, of course, just to highlight how poor the visual quality is. You can see the E chart being very, very distorted over there. Now, of course, Shreyas has already covered this. You can look at PTK as an option, but with PTK, there is some amount of hyperopic shift expected. A lamellar keratoplasty, say a FALC or a SALC procedure, could be done also at this kind of depth of scarring. But this case was actually managed in conjunction with the team at Narayan Nethralaya, and actually this patient presented to me in Delhi, and then consequently, I happened to be in NN when the laser procedure was done for the Trek. We didn't have access to the Schwinn machine at that point in time. So with that in mind, it was thought that Trek had already been described for keratoconus, where a PTK, customized PTK on the Schwinn platform was done in the area of the cone to remove the epithelium and some amount of stroma to just kind of shave off the cone and give you a better topographic and visual outcome post keratoconus. So the idea was to kind of use this in this particular case and try to leverage this to improve the refractive outcome as well. This has subsequently been published in the EJO regarding this particular technique. So it's done on the Schwinn Amaris platform. The PTK CAM module of the Schwinn is used. You can see that the mapping of the scar, it shows a long and a short diameter of 5 and 3.5 mm. And you can actually customize the area of PTK within this machine, which is a big advantage. So you don't have to do a flat, large area of profile. You can actually treat in that. So the offset actually is showing that it's been customized to the area and of the scar. And this is how the ablation profile looks on the machine, where you have a customized decentered ablation to take care of the scarring with the PTK. This is the actual laser being done. You can see here, there's a static cyclotorsion compensation. The images are taken from the Cirrus topographer and then exported into the treatment platform on the Schwind. And overall, surgically, it's a fairly straightforward procedure. You can see here that once the images are good and you have a good amount of good quality of image, it captures well and it can be done fairly easily. Post-operative management for this patient included the usual topical moxifloxacin and prednisolone eye drops along with topical sodium hyaluronate. Later on, once the epithelium healed, cyclosporin A was used. And 1 month post-operatively, the best corrected improved to 20/30. There was a reduction in aberrations. You can see the comparative maps on the pentacam. You can see that the central area where the scar was initially has got much better, and you can see that focal area of flattening over there, which has been achieved by doing the Trek protocol for this particular scar. So this is just a comparison of the pre and post-operative. At about 3 months, this patient achieved almost 20/20 vision. She's been on subsequent follow-up with me in Delhi and is doing well. And in fact, now is independent of glasses as well, which has been a bonus for this patient considering how she presented initially. So you can see that the OCT image also shows that there's a very, very faint kind of scar just below the Bowman's layer, which has got left over. But overall, a significant improvement in the quality of vision as well as the topography of this patient. To summarize, this is a novel technique which can be used to kind of treat these corneal scars. I'd like to acknowledge, of course, Dr. Rohit, who had actually performed the surgery for this patient. Dr. Vetish and I were in conjunction managing this patient, and Dr. Ritu, who had actually initially referred the patient to us. So with that, I'd like to conclude. Thank you so much for patient listening.
Thank you, Rishad. We'll invite Dr. Deepthi to present her case of topo-guided PRK for case of irregular astigmatism related to scar. While we wait for her to start, I think Dr. Audrey had a question for Vineet. Dr. Audrey, you could go ahead and quickly ask him that.
Yes, I wanted to know if the cells were mixed with the fibrin glue itself, or obviously with one component or another. I did get the answer, and that it was mixed with the fibrin component.
Yes.
That is the ideal. And so very, very interesting work there, fascinating work.
Thank you, Dr. Osto.
Slides visible, Dr. Rishi?
Yes, please.
Yeah. Thank you so much for having me here, Dr. Rishi, and truly enjoying the saga of cases in corneal scars. So I think, as you rightly pointed out, there's a very thin line and not a very thick line where you start looking at scars in a therapeutic treatment like PTK and go towards a refractive treatment like topo-guided. I think that junction of where you stop looking at it as a therapeutic and start looking at it at a level of being glass-free or reducing the power is the key of success. So shifting from PTK to when we start looking at a refractive solution for the patient, I would just present this case. So this was a boy who presented to us a few years back. We had performed a Dalk a few years back, and he was off treatment. And now he had a mild nebulomacular gray scar, and he came to us with an uncorrected vision of 660 with a spectacle corrected 6/9 parts. And his wish now was to be less dependent on glasses. He never liked it. He never wore them. And he also had this squint, which cosmetically he wanted to be better. So let's see how we do step by step. So when you're looking at a PTK to start looking at a refractive, one of the key component is what is his BCVA. You can do an accurate refractive surgery on scars only if your BCVA is good. There's no guideline, but I think clinically a 612, 615 is a good start to start looking at a refractive procedure. So the number one test, however smooth or irregular your cornea is, is what the patient perceives. Yes, there will be some debulking of the scar. The vision does improve, but you should have a baseline to start looking at refractive rather than a therapeutic BTK. So this was an ideal patient because his refraction did give him a good vision of 6-9 parts. And very important is also the health of your cornea, especially because this was a post-grafted eye, even before you start looking at a refractive solution for him. So the plan for him was to do an excimer laser followed by a squint surgery. So this was his pentacam and just a lower layer of the refraction again. Now I'll just take you through the thought process which we had and the challenges that we had to face when we were planning his surgery. So the first thing was, should I plan a surface or a flap? The thickness was quite good. So OCT is the only tool where you can decide on all this in scarred corneas. So if you look at the OCT, there is a lot of irregular epithelium. This is expected when there's a scar or an irregular cornea. And you also see a lot of scarring at the deeper part of the epithelium and also at the Bowman's and a little bit of stromal area as well. So what does this tell me? There is an irregular scar and irregular epithelium. Now, if this was a patient who had irregularity but was a clear cornea, I would probably start looking at a flap because that would give me a nice plane to start my refractive procedure. But obviously in this patient, our intention was to debulk the scar, so it had to be a surface ablation, no doubt on that. Now, how do we remove the epithelium? Now we have a lot of options. We do generally an alcohol in a regular surface ablation, or we also have an option of transepithelial where we use an excimer laser. So in this patient, it was very irregular. So how do you decide is basically look at your visual center, maybe the 3 or 4 millimeters. So the lower OCT is of his center. So it was somewhere between 70 to 90. So we decided to go ahead with an 80 micron ablation. So how do we do it? Alcohol certainly is not a good option when you have scarring at the Bowman's because your base itself is going to be very irregular. So it has to be an epithelial, a streamlight, or any transepithelial platform that you use. So we decided to do a epithelial removal only with an excimer laser, and we decided to remove around 80 microns for him. Now, when you look at what type of ablation, these are the typical cases where you would certainly want to go for a topo-guided. So if you expand his center 3 millimeters, you do see there is a significant irregularity, and these can beautifully be dealt with any sort of topo-guided Placido or a Schleimpfler-guided ablation. So another interesting thing in this patient before we started planning is if you look at his pentacam, you see that his pupil is up. This is not a fixation error. His pupil is slightly up. That means he has a very significant angle kappa. So he's actually seeing the world, if this is the left eye, seeing the world through the inferior temporal part of the pupil. Now, this is extremely important when you plan excimer laser. If you look at the overlay of the pentacam, it almost shows a 1 millimeter deviation inferiorly. Now, as we know, another simple way is just go to your pentacam, and you can also always see the fixation in the upper left corner, and it shows the patient's fixation is quite significantly inferior temporal side of the pupil, which has a significant angle kappa. Now, this is easily corrected with most of your topo-guided because a contour or any such platforms automatically go and treat your visual axis. But if you're not using a topo-guided, it's very important that you decenter. For a simple reason is this is again the Placido showing a significant angle kappa. And if you're not decentering it, a regular laser would put it around the pupil or center of the pupil like this, but actually you require a treatment somewhere here. So you can visualize this. This was a patient under the microscope where you ask him to look at the fixation light. It is quite inferior. If you can see my cursor there. Compared to your pupillary center. So for us, it was not an issue because it was contura, but this is something you have to look for. So if we go ahead with the pupil centering, it's almost a 1 millimeter decentered ablation, and the aberrations which you're planning to treat certainly would not be. So on the day of surgery, again, it's not very easy to get a good scan, especially if you're doing a vario or a Placido base like this. You have to repeatedly put lubricating drops, try to get good scans, and you will manage to get a few good scans in such sort of corneas. Now, the plan was to do a PTK of 80 microns. So when I started planning, I required an optic zone of at least 8.5 because the contour was that big. So when I started planning and put an 80 micron ablation thickness, the only option the machine gave me was an optic zone maximum of 5 millimeter. So PTKs do have a restriction of how much ablation can happen. So what would we do? So we thought we'll do a 2-step PTK. I could not compromise on the thickness, nor I could compromise on the optic zone. So I planned a first step PTK of 50 microns. There I could get a 6.5 optic zone, and a second PTK I planned for the residual 30 microns with a similar optic zone. Now, again, because we are doing a huge decentration in contura, I also wanted the epithelial removal to parallel it. So we had to, because epithelial removal does not have a visual or pupillary centric treatment. You have to manually decenter it. So looking at my contura decentered, I went ahead and decentered the PTK as well to the inferior temporal part of the cornea. So that was done, and I decentered it by, I think, around 400, 450 microns. So this was the PTK planning. And refraction is extremely important because the machine eventually treats what you do. So it's very important you do multiple refractions. This was my wavefront refraction, cycloplegic, and always do check it yourself. A simple duochrome and a JCC will ensure that your optometrist has not erred. So this was the plan for the day. So first step was a 50 micron decentered PTK. Second step was that additional 30 micron decentered PTK followed by the contour ablation. So you just have to plan all this in advance so that you don't want your stromal to dehydrate, which can cause overcorrection. So make sure your optometrist has planned all this. Sorry for that. Yeah. So this is the 50 micron of PTK, and you can see, so obviously it is decentered. That's how you want it. So once you're done, you immediately put in the second PTK. And this would, you would see the contura decentration is quite significant. Almost a 0.5 millimeter is where the visual axis. So this is the excimer laser which is happening. So very straightforward, absolutely a no-touch technique, and that is the end of surgery. Very important to give a good dose of mitomycin. So our protocol is around the second mitomycin for every micron of ablation. But in scar corneas, we do sometimes slightly overexposed to mitomycin. So what happens, this was the pre-op photo, topography, and the OCT, and this was at 1 month. Cornea certainly much clearer. You just want to clear the central 3 to 5 mm, and that's achieved. Topography is much smoother. So if I look at the central 3 to 4 millimeter, it's a pretty impressive smoothing. And OCT again gives us a great clearance of the scar. Almost the entire scar in the center could be treated because your excimer laser for the contour again is debulking the scar at that level. And this is what you actually want to see. The patient went from unaided 660 to an unaided of 69 parts. So a very happy patient and certainly a happy me. So the only question the patient had is, you took so many days to plan, but the surgery hardly took few minutes. And I think that is the main mantra when you are doing refractive surgery on irregular corneas like this. Your treatment has to be meticulous. You'll have to look at smaller details to really give that sort of visually satisfying results. So I think today, as we have heavily discussed till now, scars, there are so many beautiful options. And I think these are patients where you can really use the excimer or any technology to the topmost. These are irregular corneas truly benefit from the newer technologies we have. And these are the cases you have to spend a little more planning the surgery. The surgery itself is super easy, but I think planning makes the whole difference. And these are the patients who are least expecting, because I've always heard from doctors saying there's a scar, there's nothing much, and they have the highest gratitude if you really help them out. And we should also know when to reject. It's not all cases that you can look at a refractive, as Shreyas told. A lot of these intense scars do require a PTK, then only refractive. So always know when you reject for an excimer. And I think this is one area where there's no protocol. There can never be an algorithm, because every scar that walks into you is a different case. And I think the planning has to be totally different. So I thought this case was good just to see the minuscule level of planning that goes a long way in giving good refractive results to our sky corneas. Thank you so much.
Thank you, Preeti. That is really, Deepthi, that was really very nice case, and what a wonderful outcome. And special kudos to paying attention to that angle kappa and customizing your treatment and getting a beautiful outcome.
Thank you, Dr.
We'll
Rishi.
go to Vardhaman, as Dr. Himanshu suggested, and you can kind of give an overview of all these three laser options and what is your take on how to select one versus the other, and then we can invite comments for the other panelists.
I think beautiful demonstration. I think it could not be better than what all the three of them had presented, both Shreyas, Rushad, and Dipti. I think a lot of meticulous planning, because when you look at even Shreyas's cases, even in terms of PTK, when to choose only PTK versus where you have to do a superficial keratectomy along with PTK, Rushad really, I think, took the best example for Trek. And I think, as Rishi just said, Dipti is very meticulous planning, because I think this case required a lot of planning, replanning at variety of levels, but there is a lot of organizational and patience level that is required from the surgeon. So definitely, I think all the three of them, as I think this was Sayan had also mentioned it, that whenever we are looking at the corneal scars, the scars is actually affecting your vision because of two reasons. Number one is, of course, the opacification, but number two is induced irregular astigmatism. And these cases bring out the same feature, that if we are going to try and reduce the irregular astigmatism with the current technology available, we can improve the best corrected visual acuity of this patient. And so one of the first things that I try to do for such patients is, of course, give them a scleral contact lens trial. Because when you give them a scleral contact lens trial, you actually can come to know uh, if we treat such patients with topoguided treatment, are we going to actually succeed and improve his vision? And I think, many times this is also something that I have seen, that because these patients, as Ditya said, has been told that nothing can be done except this vision. But if you give them both the options, that okay, we have a conservative option, we are not pushing them for the procedure. We have a conservative option in the form of scleral lenses, and if the patients are very happy with that, you can just give it away, and then the patients will still be happy. But if the patient is reluctant to use them or wants a solution beyond, then of course all the three solutions can be great. Now, when it comes to the trach and the topoguided treatment, especially the topoguided treatment, I think one of the most important thing is to plan how are you going to remove the epithelium, because as against in the regular refractive procedures where you can actually do it manually or transepithelial manner, the outcomes will be practically the same. But here there is going to be a huge and big difference. So for all the audience who are attending, it is very important that you do epithelial mapping in all these patients very well, because you will actually see that epithelium is a great masking agent. So there is a lot of irregularity on the stroma, but because of the epithelium masking, in fact, a lot of this irregularity has gone down. So if you remove this epithelium with manual method, you are going to expose a very irregular stroma that you have not imaged the way, and then you are going to actually induce more astigmatism rather than treat it. So it is essential that you do epithelial mapping. It is also essential that you take advantage of the transepithelial PTK instead of manual epithelial removal. Number two is to have a very consistent topographic maps. So I think the case that we have seen from Dipti was very prototype, because I think this patient had fortunately not super irregular astigmatism, but was a great candidate for topoguided treatment, very consistent maps. At the same time, very consistent refraction, because in this case, as against what we always tell about the topoguided treatment, that don't fetch the refraction. We are not treating here for refractive correction, we are treating for improving the regularity. But I think Dipti's case was probably a very unique case, because even the wavefront refraction was similar to the subjective refraction. The irregularity was not too much, fortunately. So this is an exception where you can actually chase the refraction and refractive error. But I think majority of the cases, probably not a great idea to do that. So that is again some of the other points that I would like to get. And of course, I think it was mentioned about the masking agent. I think that does play a part, especially in PTK. And what one can do is use a very thin like HPMC and just brush with your like Lasik sponge just once. Make sure that it is not thick, just once, that you don't see the visco on it anymore. And that actually gives a very, very good masking. Now, whenever we are actually doing the trick and the topo-guided treatment, we are doing it also for keratoconic patients. Also, we are here doing it for scars. So what is the difference? The difference is that in keratoconus, we hardly use mitomycin nowadays whenever we are doing trick or topo-guided treatments. But in this case, because as Sen has mentioned, there is already activated keratocytes as well as, so there is a very high chance that you are going to induce a lot of scarring. So you have to use extended time of mitomycin, maybe about a minute or so, whenever you are doing trach or topo-guided treatment as against this. And the second difference, of course, is long-term steroid and cyclosporin. So as against the regular PRK that we do, or when you do a trach or a topo-guided PRK for keratoconus, in this patients of scarring, you may have a lot of let's say pre-existent inflammation in the past. So always put them on long-term steroids. So I think this is probably some of the things that I thought.
Thanks, Vardhman. That's really wonderful. You took the entire gamut of treatment and where to select what, and that's what we want from you, and that's really nice. We are really short of time, so we'll go for a quick fire, rapid fire to our couple of questions to our panelist. And Dr. Somshila is around.
Yes, very much.
Somshila, in case of a post-PRK haze, your choice would be a PTK or manual debridement with the mitomycin C. Does PTK lead to same haze again, or what would you do?
Rishi, that we, as Himanshu, post-PRK haze. So first we do medical therapy. You're assuming that we've done everything else and now we're coming to surgery.
Yes.
So my choice usually is PTK for these patients.
So the thing is that not every post-PRK haze would have recurrence of the same haze even when we do PTK, and we surely wouldn't use mitomycin C along with that. Dr. Audrey, I'll ask you one rapid fire question. What is your limit of the depth for PTK? What would be the cutoff for PTK and beyond which you would not consider PTK?
I'd say that really depends on what the thickness of the cornea is and what the thickness of the scar. So I don't think that you can just have, just a blanket term for like, I'd only go 100 microns or I only go 120 microns. I think you really also
if you have enough corneal thickness, would you have a limit still beyond which you would go for a lamellar keratoplasty or anything like that?
Yeah, I think about 80 to 100 microns is really the limit there.
Sure. And would you prefer mitomycin C in these cases?
The answer is it depends. And for example, if it's a dystrophy versus a scar, and so for a dystrophy, I don't use mitomycin. For a scar, I would consider it. But I think that the ablation of about 80 to 100 microns is certainly reasonable. You also have to look at the epithelial thickness, of course, as well.
Thank you. Thank you, both of you. So we'll move ahead.
We'll move on to the next talk, which is again by my dear friend Himanshu. Yes, Shreyas has a point. Yes.
Sorry, sir. Sorry.
Yes.
Now, since we spoke about all three modalities, I just wanted to quickly decide, give a point on when to choose what. I know we are running short of time, but very quickly, while PTK, our really aim is to ablate and remove the scarring and not worry about the refractive outcome at the get-go. But when we are using other modalities, especially if you're using a trick like where a decentered PTK and a smaller zone of PTK, it's important that we don't ablate a lot of tissue. If you are ablating a greater depth like you would do in a PTK of about 100, 110 microns, the amount of irregularity that you'll end up inducing will also be very high because you'll be just ablating over a very, very small optic zone. So that is something to be kept in mind. And topo-guided ablation, again, very quickly, the challenge with that is we are actually trying to reduce the irregularity induced by the scar and not trying to treat the scar itself. And if your aim is really to treat the scar, because once the scar goes, the topography, what will be after the scar is gone is anybody's guess. And any type of meticulous planning and pre-op imaging will not give you that extent of outcome. So I know this Deepti's case was very well presented, very well planned, But in a majority of situations, depending on where the scar is, the recommendation would be to first eliminate the scar and then treat the irregularity in a topo-guided platform, rather than trying to combine both, because the ablation rate over the scar and over the normal cornea would differ significantly as compared to a keratoconus, which is optically clear all over. So the same teachings cannot be extrapolated between different conditions. Was just a point that I wanted.
Point well taken, Shreyas, that default we should be looking at two-step procedures, and where you take care of first so that you get a better refraction and then go for a refractive outcome. So we'll move ahead.
Yes, the next speaker is Dr. Himanshu, my co-moderator and dear friend and surgeon par excellence. And he will talk to us about use of femtosecond laser for superficial anterior lamellar keratoplasty in scars.
Thank you, Rishi, and I really appreciate you giving me this opportunity. My slides are visible?
Yes.
Okay, perfect. Great. So I have short case and I was told 5 minutes. So I think let's try to finish as early as possible. I have a case where a young lady post microbial keratitis, heel scarred, stable surface, and she had a reduced vision because of the corneal scar. There's not much of deep vascularization there. Anterior surface was pretty much regular here. As you can see from the anterior segment OCT, the depth of the scar was around 220 to 230 micron. Remember, the extent of scar is very, very difficult to know. One interesting way to see on ASOCT is reversal of the image. So you do image inversion, and which increases the contrast and which can give you a little better idea. But in any case, it's very difficult to know the exact depth because there is always a gray zone there. Now, what we decided was femtosecond laser assisted lamellar keratoplasty. The scar was around 220 micron to 230 micron, and we decided we'll go for around 250 micron depth of the dissection. The donor cornea was dissected in the same depth setting. However, I prefer to take 0.1 millimeter larger of my donor cornea versus the recipient cornea. The recipient cornea, when we are dissecting, remember that depending upon the density of the scar, sometimes the laser may not pass. And when we are removing the recipient cornea, sometimes the cornea may have dissected area or uncut area. So just be aware of that. And once you remove the amount of cornea which you have dissected, again, I would prefer to take a measurement, and then I prefer to take my donor corneal dissection afterwards, so that it helps me to know that how much area how much diameter we check. I prefer to take 0.1 millimeter larger donor cornea. Younger tissue, mind you, can contract, and some of the scars which are more into the periphery and has more actin filaments can also stretch the recipient bed. So just be aware of that. We massage the cornea with the two sponge technique, remove the fluid between the bed and the flap, and put a bandage contact lens on top of it. I prefer to keep the contact lens for at least a couple of weeks time, and keep them on topical steroid for a little longer time. Remember, if the donor tissue is very young tissue, there are chances that it can retract. Now, the same case post-operatively did well and had a very good vision outcome. Patient was doing well. Post-op follow-up, however, patient started developing epithelial ingrowth, which increased, which progressed. And hence, we decided to do YAG laser to take care of the nest of epithelial ingrowth. Thankfully, it responded well, and patient had an excellent vision outcome at the end. Coming to such kind of cases, what are the small surgical tips which I would like to convey? One is the size of the donor and host. Usually, I would like to keep the disparity of 0.1 millimeter. However, it also depends on your laser platform. Some of the laser platforms have a different way where it cuts the tissue, and you may get away with the same size, but I would still say 0.1 millimeter larger can still work, because If the donor tissue shrinks, then in that case, you will have large gutter. The depth wise, whatever depth you have measured on your anterior segment OCT, I would like to go probably 20 micron more than that, and avoid cases with deep vessels and active inflammation. I would surely avoid the cases where there are the scars related to something like HSV keratitis, and I would not want to touch these corneas. When we are doing the dissection, the laser dissection, it's very important to mark out the geometric center of the cornea, whether it's a donor cornea or a recipient cornea, to have proper centration of the treatment. Remember that these cases, we do not need to put the vacuum ring there. Hence, it's very important to stabilize the trolley there. Whenever we are putting the applanation on the cornea, if the globe is too soft, it may have an endothelial touch and it may not actually recognize the back pressure. If the globe is too tight, then what's going to happen is it's not going to achieve the proper meniscus and you would not be able to dissect the cornea properly. So make sure the intraocular pressure in the artificial anterior chamber is adequate and it's not too tight or too soft. Remember, as I told you, that if the tissue is young and if it starts curling up the edges, sometimes it becomes very difficult to take care of such kind of things. Please do not shy away from taking the stay sutures, and it's absolutely okay to take stay sutures, and you can remove stay suture after probably 2 to 3 weeks time, and they do really well. In this case, I was lucky enough to uncurl the edges and I could still get away. But please remember, if in doubt, if there is no harm, and do not shy away from taking stay suture. So femto versus manual, where femto has an advantage of precision and planning and everything, whatever best matching and everything, but it has disadvantage where you have scarred cornea. It's not going to help you to dissect through that scarred cornea. Femtosecond availability can itself be one of the disadvantage. And in these cases, manual ALTK is also a certainly good option. So what do we learn from here? Well, femto-assisted SALK is a simple procedure. Proper case selection is required. Sutureless would be something which I would prefer up to 250 micron. Beyond that, I would like to take the suture. And beyond 300 micron, I would prefer to do a Dalk rather than doing a SALK here. Thank you very much.
I think that is an excellent case. I'll invite any of the panelists who would like to comment on their experience with FALK or SALK. Dr. Audrey, Dr. Somshila, or anybody else among our speakers.
I think that was a lovely presentation. Thank you so much for that. And yeah, I agree that more than about 250 to 300 microns, you're just better off with a Dalk. If it's a thinner case, then sometimes actually I've just simply done, rather than a PTK, there are those cases in between. If there's enough cornea, just simply and essentially make a LASIK flap, a thick LASIK flap, and remove it, and you'll get the bulk of the whatever it is, the scar, the dystrophy, and such, and that could be a nice option as well.
Sheila?
Yeah, I just want to add that the utility of FALK for me is limited, but I think two very good indications for FALK are in cases of GDLK, gelatinous drop-like dystrophy, and the second one is Rees-Buckler, the variant where you have the recurrence of the dystrophy always in the anterior layers. So the earlier days we used to do PTKs for these patients, but then after a few PTKs, you now have a tissue which is very thin, so you want to add on. So you know that this disease will recur throughout life, especially the GDLK, which happens in young patients. So with FALK, there's a lot of repeatability, so you can keep on doing FALK for these patients. Ultimately, you have to do DALK and sometimes even PK for these patients.
One interesting thing which Dr. Audrey touched up, that's really nice, that sometimes even the LASIK flap, and especially even if you do not have femto laser, but even if you have MK, and if you want to do such kind of thing, it's possible. You can make a flap, a little deeper flap, put the flap back, let it heal, and then go ahead in the second step with a smaller trephination and just remove that thing. And similarly, do a donor trephination with similar size, and it works equally well. And surely something which can be considered. Thank you, Dr. Audrey.
Dr. Vineet has something to say.
Dr. Himanshu, hi.
Hi,
This
Vineet.
is great series. Okay, so I wanted to ask, you mentioned about the 0.1 disparity in horizontal or XY dimensions, but about the depth disparity because of epithelial swelling, usually how do you take care
Sure,
of
that's
that?
a very good question, Vineet. So if my donor cornea is so this case I was talking about more to do with this case. So this case, if you remember, had a very regular epithelium. So I didn't have to do an epithelectomy there. Even the donor cornea had intact epitheliums. If not, you have to keep in the mind that 50 micron, which we would lose from the donor corneal epithelium. Also, donor cornea deterges and it becomes a little more compact after a while. So just keep in mind that particular aspect. But large diameter, when we are taking such kind of thing, a small dip there is not very very dangerous and very bad. It usually does happen that when you take the donor cornea, you might want to take possibly a few micron more, as in 20 micron more than what you would take from the other recipient cornea, depending upon what kind of tissue you're using. If you are using a good quality tissue, not very edematous tissue or something, where I don't mind keeping it very similar.
You usually remove the epithelium before fashioning the donor tissue.
If it is loose epithelium or devitalized epithelium, yes, it goes off. If it is not, if it is clear, pristine cornea, I don't mind keeping it. But if at all it's not so great, of course it goes off.
We'll move on in the interest of time. Next speaker is Dr. Rasika Thakur. She's a cornea specialist at Agarwal Hospital, Kalyan, Mumbai. And she's going to talk to us about cataract surgery with Toric IOL in the case of scar.
Hi, good evening. Can you see my screen?
Yes, it's visible, Rashika.
Yeah. Thank you, Dr. Rishi, for this opportunity. I'm Dr. Rasika Thakur. I will be talking today on Toric IOL in post-RK scar. So this female, 57-year-old, presented with the diminution of vision. On examination, like you can see, there are 8-cut RK with a central cornea scar, which we cannot appreciate right now because there is a dense cataract as well as anterior capsular fibrosis. Her refraction she was using was very much hyperopic, which is expected in RK cases, that is plus 5.5 with a high cylinder, that is -4 cylinder. And so when her topography was done on the Placido disc, you can see the rings are very highly distorted. And similarly, we can see her topo images where, unlike other refractive procedures like LASIK and PRK, where only the anterior corneal curvature is affected, in RK, the more both the posterior as well as anterior. I'm so sorry. Can you hear me?
Yes, Rasika, we can hear you loud and clear.
Yeah. So, like in RK, both the anterior as well as posterior corneal curvatures are affected, and there is a lot of central corneal flattening. Like you can see, the K readings here are 32 and 37. We did a anterior segment OCT for her to see the depth of the scar. So you can see the posterior corneal curvature is markedly affected, and also there is hyperreflectivity in the center, which correlates with the central corneal scarring as well.
As this patient has previously undergone RK for a spectacle-free life, even now after cataract, she was expecting the same. So our plan of management was to give her a toric IOL and try and reduce a post-surgery refractive surprise. For that, so when we tried doing a biometry for her, there was actually we couldn't get any images because of the central scar. We just got was axial length. So we went ahead and used the topography keratometry reading and got a preliminary report. And then we went to the ASCRS calculator, and then we got was 23.5 diopters. So I normally prefer keeping a patient 0.5 to -1 myopic, because these patients tend to again land up in hyperopia later. So we went ahead with a 24 diopter lens. So the toric placement for this patient was, we used a T8 lens, around 6.75 cylinder was there at the cornea, at the lenticular plane. And 0 and 180 was the placement, and depending upon her toric, depending upon her RK cuts, we fashioned her axis of incision basically. So I did not mark here, because when I took the patient for marking on the slit lamp for 90 degrees, I realized the 0 and 180 marks are correlating with the RK marks. Special care in these cases are to be taken are we have to stay away from the RK cuts while making the incisions all the time. The phacoparameters has to be very, very low. Vacuum has to be very low. And we have to make sure that the AC fluctuation should be minimal, because these cuts can gape and open at any point. If you feel they are opening or there is gape, you should take a suture. But thankfully here that did not happen, and we went ahead and we implanted the lens, a toric lens at 0-180 placement for this patient. Also, very important thing is we have to be very gentle with the hydration. We have to stay away from the RK wounds while hydrating, and minimal hydration is good. So majorly we should avoid is high phaco energy crossing the RK cuts and overhydration. If you find micro leak, suturing is a good idea. This patient is doing very well. We operated both her eyes with toric IOL, and she is unaided now, 6-9 parts. These are pre-op and post-op images. In post-op, you can actually appreciate the corneal scar, which is just there. The RK cuts are also almost extending to the pupillary axis, where there was barely 1.5 millimeter clear zone remaining. Take-home message, even with the toric IOL implantation, the counseling is very important for these patients, because their expectation should not be very high, because there is a very high chance of refractive surprise. The incision placement for me for this 8-cut RK was easier. If you have a case of 12-cut or 16-cut or more cut RK, scleral tunnel is anytime a choice. And when to select toric IOL, is it necessary to go for a toric IOL, or I could have gone for a monofocal as well for this patient. So the patient selection and the scar, where the location is, and the topography images, if they are repeatable, then according to that we can plan for toric. Thank you.
Thank you, Dr. Rasika. That is an excellent presentation and very interesting case. I think toric IOLs do have a place, and especially when we are looking at topographies, if we see a little bit of irregularity, it becomes a bit of a dilemma whether this kind of a case can be used with the toric lens or not. Is Dr. Rohit Shetty joined us yet? I saw him appear once. Is he here? If not, I'll request Dr. Audrey to help us with that. In cases like post-RK, where we have some element of irregularity, how does one select whether to go for a toric or non-toric? In this case, she used a toric, and luckily she got a great outcome in spite of some element of irregularity.
I think that you can actually really get a lot of use out of toric lenses with these type of cases with irregular astigmatism, whether it be from keratoconus or from, for example, an RK scar, and have had very, very good success. So I'm a fairly large proponent of this. I think one of the main messages is to try to instill in the patient that the goal is improvement and not perfection. And I think that that will really help a lot. But I've had 20/20 vision uncorrected after keratoconus and after RK scars. The unfortunate thing is that when you get that on the first eye, they then expect that on the second eye. And so that sometimes is a challenge. But I've also, because we don't have as high a power toric lenses available as you do, I've even stacked toric lenses to try to achieve better vision, but that's limitation I have in my country. So very nice presentation.
Thank you. Dr. Himanshu, anything you have, any experience? I know you've used extremes of toric lenses for many cases. In post-RK, have you?
I totally agree with Dr. Audrey there, that many times we forget that we are dealing with different set of patient versus those clear-cut cataract cases. Now, somebody who has a very high cylindrical power, and if you are able to reduce that cylinder, though they may have residual ghosting effect, but that itself would change the quality of life. So I'm not trying to say that every case of irregular cornea should be treated with toric lenses, but please do not shy away giving these cases a chance. And Rasika nicely showed that her case could actually be treated quite nicely with a toric lens. Now, other interesting part here is the target which she touched upon, that we should have myopic target. Now, another advantage of myopic target is that many of time, and especially in India, when you have RK cases which are long back done, and they may have some of the epithelial irregularity, maybe the cuts may be too many in numbers, and there can be little scarring in the visual axis. Now, if you have a myopic outcome, a PTK later on can actually help them to get a little better visual outcome. So I would surely, and they have tendency of hyperopic outcomes. So if we target little myopia there, would surely be of help, and it surely can help us to plan out the next procedure if at all needed.
Thank you. We're running really back on time, so we'll go on to the next one. So next is one of the important interventions that we have to do for really bad scars, which is deep lamellar keratoplasty, and I'll have Dr. Prafulla quickly show us a case about that. I will request the speakers to quickly be on time so that we don't overshoot too much. We're already towards the end of our time. Dr. Prafulla, we can't hear you.
Praful, we can't hear you.
Am I audible now?
Yes,
Yes, doctor, you are
yes.
audible.
Okay. And my slides are fine?
Yes, your slides are visible and you're audible. Thank you.
So DLK versus PKP in corneal scar. So we know Dalk offers you a lot of advantage. This is one case where one of the advantage, that is the better tectonic strength, was the main guiding point for going for Dalk rather than PKP. It was a 35-year-old Downs baby. If you see here, he had history of repeated trauma. That's why there is the periorbital fat atrophy. And because of this trauma only, slides are not moving. Yes, so he had hydrops, you can see here, and also a traumatic cataract. So the hydrops, at that point when he had hydrops, he had some respiratory difficulties. So the surgeon had to go for conservative management only. No surgical intervention could be done. And so, as I said, the dilemma was to go for a PKP in a patient who has history of repeated trauma. and knowing that the graft dehiscence risk will definitely be there versus Dalk, which may offer a better tectonic strength. So we thought of going for a DLK in this patient. And since it was a dense scar, the ideal way was to go for a manual Dalk. The central cornea was marked and partial trepanation was done. Vacuum trepan was not working in this patient, maybe because of corneal irregularity. So I had to go for a manual trepanation. Any manual Dalk you perform, the first major challenge is to reach the adequate depth. And every Dalk surgeon has their own way of reaching that. So you can try blunt instrument, manual dissection using Vanna scissor, Lamellar dissector, a combination of all of these to get an adequate depth. And we have seen the report by American Technological Assessment. Ideal depth would have been 50 to 80. I prefer 60 micron depth. Since he had cataract, I went ahead with cataract surgery also. It was a fibrous calcified cataract. So it was not possible to do a CCC. So I went in with the MBR, then made an entry into the intercapsule. Then I cut the capsule open and then I went ahead with the cataract surgery. So I'll skip the cataract surgery part. Then similar to routine DLK, you have to put 16 suture. So 3-piece IOL was put and a Dalk was completed after debriding the donor endothelium. This was the second case. So this was the post-op picture. You could see there was some visible area of clear cornea, and we expect that the patient may be able to get at least some functional vision with that. This was the post-op picture. This was the second case where the patient had undergone left eye PKP followed by infection and a thysis bulbi. Right eye, she had repeated history of keratitis, most likely viral keratitis, with a scar like this. And again, the decision was to go ahead with Dalk was made because the cornea was vascularized and the other eye had infection with thysis bulbi. So we did not want to take a chance with PKP. Here again, as I was saying, the first challenge was to achieve adequate depth. Here I use a guarded knife. As for manual dissect, we used to use this guarded knives. This was the guarded knife I used. That was a 400 micron, sorry, 350 micron. And then once the adequate depth is achieved, you can go ahead with manual layer by layer dissection. But one has to remember these cases are different from keratoconus stroma. In keratoconus stroma, the layers structure of lamella may be still maintained, but in a fibrotic cornea, you don't get such lamellar structure, and you may have to repeatedly start from a new plane. And one thing when you feel that you have to start a new plane or you are losing a plane, it's better to use a sharp but blunt tipped instrument like Sinsky hook or Siebel's flap elevator can be used to create a new plane and then go ahead with the further dissection with that. And you have to attempt multiple times. Single attempt may not give you the adequate depth, as was that in this case. So I had to peel multiple times, and finally, when luckily we have this microscope integrated OCT with us. So when I was confident that my stroma is smooth enough and thickness is thinner enough to provide some visual acuity to that one-eyed patient, then I went ahead with the DLK. So this was the donor cornea. We use non-optical grade for DLK. However, the edema resolves in post-op period. Here you can see the graft is quite edematous, but subsequently the edema will resolve and the patient will get a good visual acuity. So this is the third case. Here you can see it was a patient of macular dystrophy with recurrent epithelial erosion, and there was a healed keratitis with a scar. But the pre-op ASOCD suggested the depth was not that much. So in such cases, you can go ahead with a big bubble DLK procedure. Here I went ahead with the big bubble Dalk, and I got a type 3 bubble, a mixture of both type 1 and type 2. You could see here the microscope integrated OCT showing that. So however, Dalk could be completed successfully. Such patients, they usually Dalk is useful. However, you have to ensure that your endothelium is working fine in these patients. So depending on the case, either you can go for a manual DLK or you can go for a big bubble Dalk. Similarly, this was a case of healed hydropsin keratoconus. In the interest of time, I'll skip this video. Here again, a manual DLK was performed and that was quite useful. So important point to remember, you have to select cases depending on, because all this patient, if you do a PKP, definitely the quality of vision will be better. However, as I enumerated, there may be some points that push you to go for a DLK. Pre-op ASOCT is must. You have to ensure endothelin is working fine. And as I was telling, the stroma is different from keratoconus. Don't think that it will behave like a keratoconus DALK. Trust your technique. As you saw, I used three different techniques. So I have seen every Dalk surgeon, they have their own way of peeling, doing manual dissection. So if you are expert enough, please trust your technique. But if you don't have that much expertise, better to refer or go for a full thickness graft. Take care of the vessels. These cornea are usually vascularized. So pre-operatively, you can do laser or diathermy and take care of the vessel. Thinner the better. 50 to 80 micron is good enough, but I prefer thickness of less than 60. AMG slit, if you feel that, if you remember the heel keratitis case, the surface was very poor. Such patient you can combine with AMG, and if you suspect some stem cell disease, you can combine with slit also. Post-op, you have to ensure, you have to counsel the patient. The recovery won't be as good, as fast as keratoconus DLK. Epithelial healing may be an issue. And in India, it's very common to get to heel keratitis cases because of viral etiology. In that case, post-op acyclovir prophylaxis at least for 6 months and maximum for 1 year is what you should be doing. Counseling, you have to counsel the patient. The risk of complication, poor vision, interface haze, all these things are there. The patient has to be counseled properly. With this, I'll conclude here. Thank you.
Thank you, Praful. That was really wonderful. And in interest of time, I think I'll request Dr. Rishi to give one salient feature, some tip, and then we move on with our next speaker.
I think
Dr.
Praful covered
Prabhat
everything. I'll only like to make one comment. Even in cases that look like they need a penetrating keratoplasty, often if we just do a DALK, we may leave behind a little bit of a scar in the bed or in the DM, but very often it is not visually significant. Even if you can take them to 6/9, 6/12, with time, with remodeling, they often get reasonable outcomes. So, but the advantage of not having a rejection is a big one, and I
Dr.
think.
Praful, can you stop sharing? We can request meanwhile Dr. Prabhat to, Dr. Prabhat, you can, sorry, Rishi, go ahead, please.
Yeah, so that's basically the point I was making, that whenever possible, do a DALK. And
usually this scar, as you said, over 6 to 8 months, it becomes thinner and more clearer.
Yes. We'll invite Dr. Prabhat to talk about something different, how to handle scars with optical iridectomies, which he's done for one of his cases.
Thank you, Rishi sir. Thank you so much for asking me to make this presentation. I hope my slides are visible and that you can hear me well.
Yes.
All right. So my case is a 5-year-old female with a history of left-sided facial eruptions along with left eye redness 2 months prior to presentation, with a best corrected visual acuity of CF at 50, left esotropia having already set in, and left side variably pigmented facial scars. So this was the slit lamp image from that point in time. And what you're seeing is a dense scar obscuring the visual axis. You've got deep vessels. The rest of the cornea is relatively clear, and the edge of the scar is a little bit ill-defined. So there was stromal edema at that point in time. And that is visible here on the ASOCT as well with the edematous cornea. Corneal sensations were absent. There was also a central anterior subcapsular cataract, which was a small localized one, along with left-sided optic nerve head hypoplasia. So we started topical steroids and lubricants because we suspected that it was a viral etiology, and we referred her to a pediatrician who diagnosed the skin condition as a healed pox and started her on oral acyclovir 300 milligram 4 times a day. This image is from about a week or so later with little bit of compaction in the periphery of the scar because it was responding to the topical steroids, and the same is also visible on ASOCT. Given her age, we felt that it was probably appropriate to first try an optical iridectomy. So since in children, if you have an inferonasal relatively clear cornea, that is where you should do it first so that they can use that area to visualize whatever they want for near. In the frame that you're seeing right now, you can just make out the central cataract as well. So we did a scleral tunnel method. So you do a peritomy, do a limited cautery, inject viscoelastic, make a scleral groove similar to SICS, but you have to do this inferiorly, so there are ergonomic difficulties. dissect the limbus, dissect the cornea, almost exactly like an SICS tunnel, in fact. Keratometry, we have to be very careful. So you pull the iris out until you've actually pulled out part of the pupil as well. Cut whatever you have pulled out, and now you will slowly see the iridectomy expand to its appropriate size. So once that is done, you may choose to take sutures and close the conjunctiva. So this is the iridectomy on post-operative day 1 in the right-sided image versus the pre-operative image on the left side. And you can see that it's a fairly large iridectomy that should ideally provide enough space for the child to see from the side. So the patient was seen 1 month later and advised 6 hours of patching in the right eye, which was the better eye. However, they were not compliant with the patching regimen. 4 months post-op, a dilated refraction was rechecked and a fresh prescription was given that I have written here. And patching, 6 hours of patching for the right eye was advised again. What you're also seeing here is that the scar has compacted fairly well, so the cornea has almost completely reassumed its normal thickness. 6 months post-op, the vision did improve to CF at 2 meters with glasses, but there was no further improvement. And you can see the size of the iridectomy here, and you're also seeing that the corneal vascularization has reduced a little bit. But because there was no further improvement, we have advised, or rather discussed, a deep anterior lamellar keratoplasty under guarded visual prognosis. However, subsequently, the patient was lost to follow-up. So when we look into literature, we find that the largest series that I could go through was of 29 eyes of 22 patients who were all operated for Peters anomaly. And the authors have mentioned that the mean BCVA did improve significantly, but that the visual improvement was significant in eyes with bilateral disease, not in unilateral disease. We may kind of draw a parallel with congenital cataract here, wherein the visual recovery in a unilateral cataract is much less because of the density of the stimulus deprivation amblyopia. The largest Indian series that I found was of 22 eyes, and they have mentioned that there was no statistically significant improvement between pre and post-operative visits. So I guess it's probably the uh, severity of the amblyopia that precludes excellent outcomes in these patients. So the dilemmas in this patient are, how long do we wait to treat the viral keratitis before intervening? So I had waited for 2 months and then I went ahead with the procedure. Should I waited for longer or should I waited for lesser time, given the fact that the amblyopia is a serious concern? How long do we wait post-optical iridectomy before performing a transplant at the age of 5 years? Do we at all advise a transplant, or we just decide that that would be it? And given the fact that the corneal sensations were absent, what kind of complications do we anticipate? And finally, do we expect a Dalk to do as well as a PK, or vice versa? Thank you.
Beautifully managed case, Prabhat. I think in the circumstances, this was probably the best that you could have done for your patient. And wonderful. Is Dr. Somshila there? Maybe a quick comment and then we'll move on to the final one.
Yeah, it's just that there is some controversy about, well, I don't know, amongst us about surgical iridectomy, optical iridectomy rather. So I guess it depends on whether it's a pediatric versus adult patient. And so the problem with the iridectomy is that it does compromise in some ways the outcome of the corneal transplant subsequently. A single-line patient will not be able to follow. We all know these cases. We all have the will not be able to maintain graph. So it's sometimes prudent to just provide ability vision and enough for them to do their daily activities of living, rather than aim for a beautifully done keratoplasty only to have the patient not come back and end up with a very bad outcome. Again, science works here also.
Thank you, Dr. Somshila.
That was the question, whether to go ahead with the graft or not. So, at the age of 5, we're still
that's right.
Really, yeah.
Our final case presentation is by Dr. Tejashree Barghare from Narayan Netrale, and she's going to be talking to us about the new kid on the block for the management of corneal scars. We've kept the best for the last, which is losartan. I hope Dr. Rohit Shetty is around. We'd like you to discuss this case.
Yes, just joined.
Great.
Good evening, everyone. Today I'll focus on how losartan behaves in corneal scars using a few cases. So this is how a corneal scar appears on ultra high resolution OCT. The tear film and the Bowman's layer are well delineated here with focal disruption of Bowman's over the scar. This allows us to move beyond simply looking at a scar on OCT and instead appreciate the morphology of the scar. The epithelium and the Bowman's layer overlaying the scar shows remodeling, and the center of the scar is densely fibrotic, while towards the periphery of the scar, there are multiple healing pockets. In addition, the linear bands are seen running through the scar. These are traction lines, which indicates that the scar is still biologically active with ongoing mechanical forces acting within it. With that background, I will move to the first case. This was a 44-year-old male with trauma from a tree twig presenting with a sealed lamellar corneal tear. He was already on appropriate antimicrobials, and while the eye was quiet, the scar persisted and did not respond much to topical steroids. The second case was a 32-year-old male with heel contact lens induced keratitis. The infection resolved, but a persistent corneal scar remained, which was again unresponsive to topical steroids. And topography showed astigmatism of around 6.3 diopters. Third case was a 26-year-old female who developed post-PRK haze, and the haze persisted despite topical steroids. To understand why steroids are often insufficient, we have to look at the underlying biology of the scar formation. So TGF-beta drives activated keratocytes to differentiate into alpha smooth muscle actin positive myofibroblast, which these myofibroblasts deposit disorganized collagen and lead to scar formation. While steroids can suppress keratocyte activation, they do not counter the ongoing TGF-beta signaling. As a result, the myofibroblast activity persists and the scar remains there. So this is where losartan comes in. Losartan, which is an angiotensin receptor blocker, suppresses TGF-beta driven scarring in the stroma by inhibiting the ERK-mediated signal transduction. Trehalose also acts along this TGF-beta pathway to limit the fibrosis. So basically, losartan and trehalose act synergistically in a case of corneal fibrosis. So at Grow Lab, we formulate losartan eye drops through a carefully standardized process. The lamellar airflow is cleaned and losartan potassium powder is weighed and added to a trehalose-based vehicle in a sterile tube. Once fully dissolved, the solution is filtered through a 0.2 micron vacuum filter and transferred back into a sterile tube. This filtered losartan is then bottled using a 10 ml syringe, which is sealed with a paraffin strip and dispatched. Subsequently, we filed a patent application for this novel combination of losartan 0.8% with trehalose 3%. So in all these three patients, losartan was administered 6 times a day for 3 to 6 months. Coming to the outcomes, in the first case, the post-trauma scar showed a clear clinical improvement. And on high-resolution OCT, there was a reduction in both scar density and the scar depth. In the second case, there was a clear remodeling with a change in the morphology of the scar, which is shown here with the blue arrows. Topography showed improvement with astigmatism reducing from 6.3 diopters to 2.8. In the third case, there was complete resolution of the scar. Also, this is an additional case where treatment was initiated immediately after resolution of the infection. Although the treatment is still ongoing, at 1 month post losartan, there was already a resolution of the traction lines. So we want to highlight here that losartan's clinical benefit is not just from reducing the scar density or size, but it also we have to also look at the scar morphology because it remodels the scar morphology, which reduces the corneal irregularity and astigmatism. Going forward, we are currently looking at measuring the TGF-beta using corneal impression cytology. Thank you.
Excellent, great research coming out of Naranetrale, and very interesting to be able to have a drop which can cure scars. Request Dr. Rohit to give his comments.
Thank you, Rishi, and thanks, AIOS, for this. One of the questions which we keep getting asked is, does it work in all scars, and why? If it should work in this pathway, it should not. It should work in every scar, because the whole complex dynamics is the same. But when you look at the fibrotic component of TGF-beta, which is what Steve Wilson and his team designed these drops for, clearly there are two pathways. One is canonical pathway and non-canonical pathway. The canonical pathway is the one which is, that Tejashree mentioned, the losartan works on the angiotensin receptors and then triggers the TGF-beta 1. So there are non-canonical pathways in scarring, which is not controlled by the angiotensin and all the converted TGF2. That's TGF2 pathways. So that means you can have a completely different pathways of scarring, which is not controlled by losartan. So losartan has got absolutely no role, even if you use for 6 months or 8 months. So it takes 6 months to 8 months to see some changes happening there, because these are very fibrotic ones. So losartan, when it doesn't work, which is what the question is asked, means that the pathway is different. The pathway of scarring is different. And one second thing which, in the interest of time, Tejashree did not mention is infectious scars, at least in the first few months, especially driven by the lipopolysaccharides from the cell walls, contain a lot of inflammation, and the losartan don't work there very well. So they need to combine with the other TGF-beta modulators like lifitegrast. Lifitegrast also has a TGF-beta. Omega-3 has a TGF-beta pathways modulation. Trehalose has. Vitamin D has. So we have to combine it with other modulators of TGF-beta. Two important points is, when it doesn't work, means that the pathway is not driven by the classical pathway. It's a non-classical pathways. And non-classical pathways, losartan don't work.
Thank you. Very interesting stuff and exciting times ahead for the management of scars. I think I'll ask Himanshu to give any final comments, and then we'll thank everybody, and we'll request Dr. Mathur, who is here, the treasurer of AIOS, to give the final vote of thanks.
Thank you, Rishi. Thank you for this wonderful evening, and you have carefully selected each topic, and it's mind-boggling that you could actually include the entire gamut of corneal scar treatment in this short time. Of course, if we had more time, we would have had more discussion, but anyway, we can always continue this discussion further in our cornea forums, and but thank you for a wonderful evening, Rishi.
Thank you. I finally invite Dr. Mathur to give his vote of thanks, and then we'll close the webinar. Thank you all, to all the participants, presenters, chairpersons, everybody, for doing such a wonderful job, and the audience, of course.
So I was traveling and I could log in and listen to the last 3 talks. Wonderful expositions all. And I'm sure our viewers must have been greatly benefited. And those who could not log in will surely go back to the AIOS Plus channel, and they have access to all these presentations. At the outset, my sincere thanks to all the chairpersons, the expert panel. Of the expert panel, I could listen to Dr. Rohit here, Dr. Somushila, and Dr. Vardhaman, and the moderators, basically Rishi and Himanshu, they both moderated the session excellently. And all the presenters like I could listen to the last 3 presentations, but I'm sure all the other presentations were highly appreciated by the entire audience. So on behalf of the AIOS headquarters, it is my pleasure to thank each one of you, and let's wind up with this. Thank you all. Rishi, you're muted. Yeah.
Let's smile for a quick picture and then we can close. Thank you.
Thank you.
Thank you.
Thank you.
Bye.
Bye-bye.
Thank you.
Thank you, Dr. Rishi.
Thank you.